Hi everyone, this is Alicia Young, and I'm going to be talking about diuretics and how they can be used as performance enhancing drugs. So let's start off with what are diuretics? They are drugs that increase urine flow and sodium excretion to adjust body fluid volume and composition of body fluids or remove excess fluids from tissues. Diuretics can be used in clinical therapy for treatment of diseases like hypertension, heart failure, renal failure, kidney and lung diseases, and a more general reduction of the adverse effects of salt and water retention. Diuretics are classified um, in many, many different ways, in different categories and subcategories. These categories are classified by site of action in the nephron, relative efficacy, chemical structure, effects on potassium excretion, and mechanism of action. There are many different types of classification. Most common ones include thiazide, loop, and potassium sparing. So thiazide is usually prescribed for high blood pressure and edema and is usually the first line of treatment. Loop diuretics are used to treat heart failure and kidney disease and are more powerful or more potent than thiazide. They're also usually used in acute situations. And then lastly, potassium sparing, they reduce fluid buildup while preserving potassium levels and are usually used in conjunction with another diuretic, most commonly thiazides. The general physiology of diuretics obviously depends on the classification, but this is in general. All diuretics act on different parts of the nephron in the kidneys, and the nephron is responsible for filtering blood and producing urine. Like I said, the general physiology effect is diuretics enhance kidneys' ability to excrete sodium and chloride, which leads to the excretion of water by osmosis, decrease the volume of fluid in the bloodstream. I am going, oh, as you can see here, there is this photo. I know it's kind of small, but we're going to go through each number 1 through 5, which are some examples of diuretics, and I'm going to explain the site of action and the physiological response behind it. So to start off, we have number 1, which is acetazolamide, and this is right here. So the site of action is the proximal convoluted tubule, and this diuretic inhibits a certain enzyme, reduces reabsorption of sedum and water, leading to diuresis, and it also can cause a slight decrease in blood pH. Super common for treating like altitude sickness, for example. Next up, we have number 2, which you can see is kind of right here and right here. This site of action is specifically the proximal tubule and then also the descending loop of Henle. And osmotic diuretics increase osmolarity of filtrate, prevents water reabsorption, and pulls water from the tissues into the urine. This leads to, they're used to reduce fluid buildup because of the pulling of water from tissues. Number 3, which is right here, we have loop diuretics, and this is the site of action for this diuretic is the thick ascending limb of the loop of Henle. Loop diuretics inhibit reabsorption of sodium, potassium, and chloride, which leads to a lot of urine output. This strong effect is ideal for conditions that need a very quick fluid reduction. For example, things like heart failure and pulmonary edema. Loop diuretics is super common to treat those. Next up, we have number 4, and the site of action for thiazides is the distal convoluted tubule. Thiazides reduce sodium and chloride reabsorption, which can cause moderate diuresis. It lowers blood pressure, increases calcium reabsorption. This is super beneficial for people with kidney stones or osteoporosis. And finally, we have potassium sparing, which is right here. The site of action is the collecting ducts in the late distal tubule. Potassium sparing diuretics prevent potassium loss while still promoting bile diuresis. It's usually combined with other diuretics, like I mentioned, usually combined with a diuretic like thiazide to balance potassium levels while also managing heart failure. Now going into the therapeutic effects, some of them include decreased blood volume, edema relief, increased urine output, and lowering blood pressure. Some adverse effects are electrolyte imbalance, dehydration, orthostatic hypotension, and a reflex increase in cardiac output. The fluid and electrolyte imbalance between sodium, potassium, and calcium is super common when taking diuretics. An example of this would be thiazides, for example. They may lead to hypokalemia, which is not enough or not enough potassium, while potassium-sparing diuretics may cause hyperkalemia. So this would be an example of that imbalance between potassium. Also, I kind of mentioned this earlier, but diuretics can have a variety of physiological effects on the body, especially with exercising, effects on metabolism, like potassium homeostasis, thermoregulation, can have effects on the cardiovascular system, the respiratory system, which can include certain pulmonary actions or our VO2 max, like our oxygen uptake. Most of the effects are related to the consequences of volume depletion and that electrolyte imbalance, like I mentioned earlier, electrolyte depletion. Exercise can also have a big effect of diuretics as well. And this can lead into a negative effect or consequences into pharmacokinetics. So pharmacokinetics are very dependent on the classification or the type of diuretic. Right here, I listed the three most common again. So we have thiazide. The absorption is usually done orally, although the absorption rates can differ slightly among the drugs in this class. Distribution is moderate protein bound with a wide distribution, specifically in the kidneys. Metabolism is minimal, but is primarily excreted in change. And then excretion is done in the kidneys, and the half-life varies by drug. For example, hydrochlorothiazide has a half-life of 6 to 15 hours, but dosing may need to be adjusted if there is a renal impairment of some sort. Next, we have loop. So absorption is rapid oral onset. It can also, you can give it intravenously, so like an IV for faster onset. Distribution is highly protein bound, good tissue distribution, specifically in the kidneys. Metabolism, partial hepatic, and is largely excreted unchanged in the urine. And then excretion is renal, short half-life, 1 to 2 hours, which makes them very suitable for acute fluid management. That is why I mentioned earlier with loop, they are most commonly used in acute situations. Lastly, we have potassium sparing, so the absorption varies. For example, spironolactone is well absorbed orally, while amiloride has lower bioavailability. So it kind of just depends. Distribution is highly protein bound, accumulating in the kidneys. Metabolism is minimal. Most are excreted unchanged, and then excretion is renal, and the half-life varies. Spironolactone have longer lives, like 10 to 12 hours, whereas there's other ones that have a half-life of 6 to 8 hours. Just another random fact, but there's limited information on the exercise effect on diuretic pharmacokinetics. I've found a couple articles and studies, but nothing, I don't know, the information is still pretty limited. Substances like chlorothiazide and hydrochlorothiazides have short elimination half-lives, So sustained exercise, for example, like an exercising for an hour or more, can actually reduce renal and hepatic blood flow, which can limit the detection in urine after exercising, which I just thought was interesting. Now going into substance status. So in 1988, diuretics were included on the World Anti-Doping Agency's list of prohibited substances. Why? Well, the two primary reasons are they cause a rapid weight loss by promoting fluid excretion, and they also dilute urine to mask the presence of other prohibited substances or performance enhancing drugs. The urine dilution effect of diuretics also allows them to be classified as masking agents and precludes their use, obviously, in and out of competition, like I just mentioned. Um, some diuretics can cause masking effects by altering the urinary pH and inhibits the passive excretion of acidic and basic drugs in urine. For this reason, diuretics are classified as masking agents on the WADA prohibited list. However, the WADA permits the therapeutic use of diuretics if athletes and physicians apply for a therapeutic use exemption. So this process was kind of long. So the therapeutic use exemption is defined as the permission to use for therapeutic purposes substances or methods contained in that list of prohibited substance or methods. Whenever they do have to be approved by a therapeutic use exemption committee based on a documented medical file before the use of the substance in whatever sport the athlete's playing in. It also should be noted that a TUE or a therapeutic use exemption is not valid if an athlete's urine contains a diuretic in association with another substance that is obviously on that prohibited list. Like it would not be valid. Because of the TUE, some athletes do use diuretics for legitimate medical purposes. However, the diuretic use is illicit. So, this is also just another random fact with exercise. It is known that during exercise, skeletal muscle temperature exceeds core temperature within several minutes, right? We get super hot. And the alteration of the body's thermoregulatory systems is a major risk of diuretic abuse. So, especially with athletes using diuretics, this can be super harmful. That's why it's important to fill out um, the athlete and the physician has to fill out this whole thing and make sure a certain committee passes the use of using diuretics for medical purposes. Um, the effect of dehydration after taking diuretics has a detrimental effect on the cardiovascular and thermoregulatory systems of the body, especially during exercise. And this can actually lead to exhaustion if you think about if you're dehydrated and then you're also exercising. Can lead to exhaustion, an irregular heartbeat, a heart attack, and sometimes even death. Lastly, we're going to go into evidence. So, in general, there is limited evidence of athletic performance enhancement following diuretic administration. I know I've listed a few things here and there, but overall, there's just not a ton of evidence. Exercise interacts with diuretics in the nephron by both enhancing and countering the effects. So, acutely, exercise promotes negative water balance and over time helps lower blood pressure. And so, this is similar to diuretics' impact. But then, exercise can also shift potassium into the bloodstream, intensifying the potassium excreting effects of diuretics. Thiazide diuretics can cause insulin resistance, while exercise combats this by activating beta cells, lowering blood insulin, and increasing glucose release from the liver and reducing muscle insulin use. There was a study, a diuretic induced cycling workload reduction study that I found, and it was performed to assess the effects of hypohydration on cycle performance, um, ergometer performance, and in the study of VO2 max was calculated in workload while cycling. Um, and even the results showed even after rehydration, muscular endurance and performance are greatly compromised by diuretic use, which I thought was interesting. Um, there were there was another study performed on middle distance runners and wrestlers, and this confirmed that diuretics decrease the effects on overall athletic performance. Like I mentioned earlier, there is insufficient data on that establishes the effect of long-term diuretic treatment on exercise capacity. But it has been shown that both single dose and short-term diuretic treatment adversely affect maximal exercise capacity and the duration of prolonged submaximal exercise. Diuretics are also often abused alongside other substances, and this is because of that masking part of diuretics. It is super common in sports where athletes need to gain a competitive edge or avoid detection of other drugs. Um, and this is because of the masking agent for other drugs. Most commonly, anabolic steroids are used with diuretics because they're not able to see that the athlete is taking those steroids. Weight class sports like wrestling, boxing, athletes use diuretics to shed water weight rapidly to qualify for a certain weight class. Or another example would be aesthetic sports like bodybuilding. Diuretics help athletes achieve a lean or cut look while they're also able to be on steroids if they wanted to. In general, athletes can use diuretics in a single dose some hours before a competition, like wrestlers for masking purposes, or they can also chronically abuse them for months, which is more commonly found in female gymnasts. But it is important to note that diuretics abused by athletes have short half-life, making it undetectable in urine if samples aren't collected within 24 to 48 hours. So as you can see, there's a lot that diuretics, a lot of good things that diuretics can do, a lot of not so good things. And so I definitely agree with the WADA list of prohibiting it because it ultimately is protecting the athlete and not only physically but mentally. And I think that the fact that they have a system that you can fill out a certain thing and go through this process to still use diuretics if you do have hypertension or whatever it may be. I think that's a great tool that athletes are still able to use as long as they're using it in a healthy way, right? And following the rules properly. Thank you.